So today we will discuss on the Blinatumomab use. So first begin with Dr. Kathleen Duffy from St. Jude Children's Hospital will speak on the Blinatumomab Humanitarian Access Program. This will be followed by the practical perspective from Dr. Revati Raj on the optimizing the use of this drug in resource limited setting like in outpatient context, and then Dr. Gaurav Narula sir from TMH will share his experience, and finally the question and answer. And today this webinar we are doing in association with Indian Childhood Cancer Initiatives. So Dr. Maharshi Trivedi first will brief us about this initiative, and then we'll move forward. Over to Dr. Maharshi.
Hi all. Thank you, sir. So I'll share my slides. Is my screen visible?
Yes, it is visible.
Yeah, hi. Good evening, everyone. This is a brief about ICCI, Indian Childhood Cancer Initiative. So, ICCI is a multi-partner initiative which aims to strengthen the government of India's program for pediatric cancer control, and it works towards the 2030 goal of 60% survival with 100% access for all pediatric cancer children. It works by adapting WHO GICC cure all technical package strategies to improve India's pediatric management and control. And the aim is to seek the mandate and work with the Health Ministry in the development of National Childhood Cancer Comprehensive Management Policy. So these are the numbers in ICCI. We initially had 11 task force. We now have 200 plus total members, 70 plus projects, and the representations are from more than 70 hospitals, um, and more than 20 are from civil societies and others. So this was the old structure. We had 11 task forces, one of which was drugs and diagnostics. And currently the drugs and diagnostic task force is merged into the access to care task force. So there are six task forces in the ICCI now, and which covers all these aspects with aiming towards a 60% survival by 2030. So I'll just brief you about what work has been done so far under drugs and diagnostics task force. So the first thing we started was essential medicine list. So the WHO has essential medicine list, which includes the medicines which are used in the childhood cancer as well. Now we compiled the list of EML, which is at the national level in India, and with each state they have their own EMLs, and we try to find out the gaps compared to the WHO essential medicine list. This poster was presented at St. Jude's convening at Memphis in December 2024, and we are in process of manuscript publication. The next thing was because we frequently see the medicinal safety issues, which are discussed in different forums and different social media platforms. So what we did was because there was no dedicated pediatric oncology pharmacovigilance structure in India, so we tried to identify the flags, drug safety alerts from the CDSCO website and pharmacovigilance of India website, and we collected the data which all cancer medicines which are used in the childhood cancer are flagged in this list. This abstract was also presented in FOCON 2025. And the other thing which we are doing, which you all might have come across, which we share on our PHO WhatsApp group, that we have started collecting data through the Google form. If anyone is facing any issues about drug quality or any unusual side effects. So this is the form and this is the QR code. We keep posting bi-weekly reports on the WhatsApp group, and we have published so far 12 bi-weekly reports. Unfortunately, we haven't received so far any reporting. So we encourage everyone, if they are coming across any drug quality issues or any kind of unusual side effects which they would like to flag, can report in this. So we can have a national level data, and then we can see how we can work forward on this with the pharmacovigilance system of India. And one of the initiative we have taken is a educational series. This is one of the first of them. because drug quality and access is one of the agenda of Drugs and Diagnostics Task Force to educate the PHO community. So this is the first webinar on Blinatumomab Humanitarian Access Program, which is in collaboration with the PHO, and Dr. Caitlin Duffy is the international speaker of this international webinar series. So I'll stop sharing my slides. Okay. So I'll introduce. So our first speaker is Dr. Caitlin Duffy. So Dr. Duffy is a pediatric hemato-oncologist at St. Jude's Children's Hospital, USA. She has received her MD from Medical College of Georgia, and after that, she has done fellowships in pediatric hematology oncology and global oncology at St. Jude's. Dr. Duffy has also received a master's degree in public health, with her main focus is on implementation science. And she has received extensive training in implementation science, and she's focused on improving childhood cancer outcomes globally through streamlining the process of treatment discovery to the clinical implementation. So her major work is focusing towards employing the implementation science methods to improve the pediatric cancer outcomes globally. So over to you, Dr. Caitlin Duffy. We are eager to hear you.
Thank you so much for inviting me. I'm going to share my screen real quick. Can you see my slides?
Yeah, that's visible.
Wonderful. Thank you again so much. It's such an honor to be talking to you all. There's so many familiar names on the call, and I'm excited to tell you more about the BHAP project, and then also kind of share the experience that over the last several years. So please feel free to ask questions, and yeah, I'm very much looking forward to the discussion. So as a disclosure, in the past, I received an unspecified grant from the Amgen Foundation. I currently serve as the St. Jude Clinical Team Lead for the BHAP project. And in that role, I provide in-kind medical expertise to the BHAP program, and I lead our medical expert panel. I don't have to tell anybody on this call, but I think we've all looked at ALL as this kind of like poster child of a disease, one that as we've had this kind of iterative improvement on the chemotherapy regimens, we've seen kind of a further improving survival now with cures kind of exceeding 90%. And this is a quote from Dr. Pui, and really just highlighting the like kind of success story of pediatric ALL. And I think one of the things that's changed over the last 10 years for this diagnosis is the introduction of novel immunotherapies and molecular targeting. And so that's really pushed us like from that 90% survival to now closer to like 95 and higher in some subgroups. And with that introduction of novel immunotherapies, I think that we're seeing a really important transition, not only improving cures further, but decreasing the toxicity that's associated with traditional chemotherapies. The challenge with novel therapies or these targeted immunotherapies is that access has been very limited. With some of the earlier therapies like the TKIs, the major challenges that we ran into were really related to cost and global availability. And so there have been previous models for how to conduct drug donation programs where a medication supplier partners with an NGO, and then those drugs are delivered directly at the patient level. I think the challenge with some of these newer immunotherapies is that there's a lot more complexity that kind of spans the health system. So issues related to cold chain management, health system capacity, making sure that at each of the institutional levels, there's adequate manpower, there's adequate infrastructure, and really recognizing that some of these therapies have their own unique side effects, which just requires additional preparation in order for teams to feel comfortable administering them. And so in my mind, this really necessitated a new approach, one that really brought together additional parties beyond just like the drug manufacturer and an NGO. One where we really included the community, where we were trying to improve access and really creating a program and a model that, in my mind, creates a methodology that helps us scale beyond initial couple of sites. So I wanted to talk a little bit about what was the landscape when BHAP was being developed. So blinatumomab was first FDA approved for treatment of relapsed B-cell ALL in 2014. And 2019 was when we started having some of these conversations about how do we, we saw the global gap, and how did we want to address that? And in the prior year, the FDA indication had been extended to frontline for MRD positive patients. And so I think that, at that time, there was a significant number of patients in that relapse refractory and MRD positive subgroups that we thought could really benefit from blinatumomab, and also recognized that what we were seeing at that time was really going to be the beginning of kind of a paradigm shift, where things like blinatumomab were much more integral parts of frontline therapy across B-cell ALL. And so really didn't want to kick the bucket down the line, to say, like, we wanted to figure out how to implement it at that time so that we would be prepared as the drug became more and more applicable. I also think that we had a really unique opportunity with blinatumomab, because with B-cell ALL, we are dealing with like the most common rare disease. And so I think, we all recognized that the burden associated with that disease was significant. It's the #1 cause of pediatric cancer-related death globally, and really thought that this was a good disease to focus on as we're thinking about how do we improve that pediatric cancer survival gap that existed globally. I also think that timing-wise, there were lots of kind of signals of change and international momentum at the time. And so the WHO Global Initiative for Childhood Cancer had recently come out. There was a lot more global focus and, I think, momentum and recognition by people in industry that we needed to focus on how we partner to improve global outcomes for pediatric cancer. And I think, again, there was a lot of added value with the fact that ALL was one of the 6 focus cancers. And so in my mind, all of these things were kind of building momentum across, across what we were doing as an academic center at St. Jude, across, the interest that was building from an industry perspective. And so I think it was really the right timing for this type of program. So in December 2019, we all kind of assembled around this common goal of how do we improve blinatumomab access. At that time, I think there were only 13 low and middle income countries that had access to blinatumomab. And we really kind of tried to be explicit in naming that this was a complex problem. And so we really needed a new type of kind of collaborative solution that was going to leverage this complementary expertise and in order to create a solution that was going to be sustainable. And so St. Jude, as an academic pediatric oncology center, as a research institution, as someone who really is focused on developing and partnering with global networks, we partnered with Amgen as the medical supplier, and Direct Relief, who is an NGO that focuses on medication access, importation, and pharmacovigilance. And so kind of brought together these 3 groups with the idea that we would develop the Blinatumomab Humanitarian Access Program, which is specifically a drug donation program and implementation effort, with the goal of providing free blinatumomab to children in low and middle income countries where it's not commercially available. We had a couple of what I have reflected on as like key principles that helped this collaboration work. First of which really being an explicit and upfront commitment, both as partners within the program and with the partners that we collaborate with. And that really underscoring the idea that we not only wanted to, say we have this thing, is it is it going to be a good fit, but rather like early on, how did we want to engage people? We reached out very early to the teams that had expressed interest in giving blinatumomab and really involved them in the process of understanding what resources we need to be cognizant of, what adaptations were going to be appropriate, and what types of resources would be useful for their teams as we think about supporting implementation. And it's really been a goal of mine that we keep these communication lines open throughout the process because as you'll see, this is a complex drug to administer, and we really wanted to make sure that we provided good support. And that support comes in a couple of different ways. I think one, we've created these comprehensive documents for the whole medical team. And I can tell you from my personal experience, like I, as a clinical fellow, had a day where we were implementing a drug at our institution. Nobody had given that drug before. The nurses had one set of information, the physicians had another like drug fact sheet, the pharmacist had a different fact sheet. And I just personally felt a lot of the angst that went on with implementing that type of drug. And so it was really my goal to try to figure out like how we can try to avoid that experience for others. And also recognizing that it's not kind of like a one time and done, but how do we create a system so that there's kind of ongoing communication and technical assistance so that we're supporting patients. And also trying to design a program that we're fitting within existing healthcare delivery systems. Within the United States, blinatumomab is not given at every center. Even within St. Jude, we don't give it at all of our affiliates. So there are some hospitals where the care is set up to a point where something like blinatumomab is a real addition, is a real priority for the institution. And there's some institutions where that's not the case because there are other aspects of care delivery that need to be prioritized. And so, we recognize that it isn't a one size fits all. And then there are going to be some centers where it is a better fit than others. We really focused on trying to partner in knowing that we couldn't go to every center, partnering with large volume pediatric oncology referral centers, knowing that while the side effects of blinatumomab can be serious, those serious ones are fairly rare, but we wanted to make sure that there was appropriate and adequate intensive care support if it was needed. Right now, this drug is given as a 28-day continuous infusion, and so really needs to be given through a central line. And so at centers where there's lots of experience with central line management. And while these indications, are changing over time, there's still a significant role for bone marrow transplant. So making sure that patients at least had access to bone marrow transplant through referral if it wasn't available at that center. We worked with teams to understand resource availability, infrastructure, understand how leadership teams were being engaged, what the staff workloads were going to be, what kind of processes or SOPs already existed at those sites, ensuring access to required supplies because one of the challenges with blinatumomab is that you need specific tubing and specific filters, which aren't always available at other centers because they're not necessarily needed for other types of chemotherapy. We wanted to understand, what experience teams had with other types of immunotherapy, and then what teams perceived were some of the training needs for the different members of the healthcare team. And so, all of that pre-work went into helping us develop the clinical guidelines. When this program started, it was really at the height, or rather the kind of the beginning of COVID-19. And so we knew that our training and our engagement with teams needed to be virtual at that time. And also recognized that we were working with teams where there was often staff turnover, and so wanted to create training that we could administer, but also could then be administered by local teams to prepare new people who came on board. And so we had this kind of suite of materials that we developed that included didactics that are specific to each of these roles, that have treatment guidelines, workflow tools, all housed within an online classroom. We work to establish local multidisciplinary implementation teams, so those team members could get in touch with us and direct any questions to our team. We have this medical expert panel that provides ongoing support if there are questions about patient eligibility or adverse event reporting. And we have a web portal where people can submit per patient requests for drug approval. We started actually giving Blina in 2021 with 3 centers and expanding to 4 centers. We kind of got to a steady state with those 4 centers and then onboarded more teams in 2023 in Pakistan and Vietnam. And then in 2024, onboarded an additional 6 centers with the kind of historical context that these are teams who had worked with Amgen in the past, had gotten like ad hoc donations, but it was Amgen's focus to really bring all of the Blinatumomab donations kind of under one umbrella. And so that's how those centers were specifically brought into the program as well. We have had exponential growth over the last 5 to 6 years. And I'm really proud to say that we have given over 450 patient supply of Blinatumomab, and not just kind of addressing patient needs, but also really building up the clinical expertise that exists at all of these sites. And I think, as you'll hear about from Dr. Narula's team, like they have extensive experience administering and managing these patients, both their physicians, their nurses, and pharmacists. We've really taken the approach of trying to create this kind of iterative culture and iterative environment so that we make sure that we're hearing what the challenges on the ground are and adapting our recommendations to really maximize what teams are able to do. And so in addition to these resource adaptive guidelines, we've tried to create space so that we're not super prescriptive of like, you have to use this regimen, you have to use this protocol, but really trying to figure out how, with teams, how it can fit into their existing protocols. And I really believe that that's important so that we kind of reflect the real world diversity in ALL treatment regimens, because I think that that's ultimately what's going to help this drug be more widely adopted and sustainable. We've created this structured yet nimble approach, and so you'll see that we've changed over time with some of the changing indications. We recently included infants with KMT2A rearranged ALL in our eligibility criteria, and try to adapt as new evidence emerges. And we've really worked to understand like how some of the different challenges can emerge across the different centers, with the idea that if we can understand what those challenges are, that'll help us better inform future implementation over time. And I mentioned that this is a 28-day continuous infusion, but there are active investigations evaluating subcutaneous versions. And so really wanting to know, like, as things evolve so that this drug could more easily be implemented, how do we support teams? I have a couple of reflections on like challenges, lessons learned, and strategies that we've seen emerge from different teams that I think are really examples of like the innovation that's taking place within each of these centers. We acknowledge, like at the very beginning, there's this real kind of tension and challenge in how do you balance what is a limited bed capacity with also making sure that patients can be very close to centers. A lot of the centers, as we met with them early on, indicated that there wasn't patient housing facilities that were affiliated with the hospitals, and so we have advised that all teams start administering Blina in the inpatient setting, and then over time, as teams have built experience, as people are feeling more comfortable, as outpatient housing is available, as outpatient support for bag changes is available, to be able to transition to that setting. But that is kind of one of the changes that we made as specific to this program. I also kind of mentioned the acknowledgement that there is some turnover within teams, and so really trying to create resources that can be used in kind of a train the trainer type of approach. The drug supply itself is provided by the drug donation program, but not what is needed to give the drug. So like the bags that are specific, the tubing that is specific, the filters that are specific, the pumps that are specific. And so we've worked a lot with teams to, both connect individuals within country. If there's one hospital that's been able to, identify a good supplier for those materials, try to connect them with other teams that might be struggling, and trying to figure out how to best optimize the importation process for those materials. Um, you know, as I mentioned, the drug is covered, but not the other components, not the cost of hospitalization, not the cost of the supplies. And so what we've seen from all of the teams that we've worked with is that there's some type of partnership with a charitable organization or with a foundation that really helps offset some of these supplies, or it's, the hospital's foundational efforts that support some of the additional costs for families so that a child, no matter their resource levels, can hopefully be able to receive this drug. We also have seen teams partner within their own ministries of health. For example, one of our teams in Vietnam, worked with the Minister of Health to approve the use of IVIG and include that specifically in their cancer care plan so that patients who get Blina don't have the added burden of IVIG costs that would limit them from getting the drug. This drug requires a lot of coordination between a lot of different teams in the hospital. And so we've seen a lot of collaboration and communication being built across these different teams, using, methods like WhatsApp to make sure that everybody's aware, and really creating additional connections within each of the hospital teams. I will acknowledge that, we've tried to be nimble and change as FDA indications or as additional manuscripts come out about what types of ways that you can use Blina. We have to, as a program that's partnered with Amgen, have to follow the FDA indications and the FDA guidance. And so that's created a structure that we have to operate within. And so, oftentimes as I've gotten communications and questions from people, that's something that I, acknowledge of a boundary that we have to exist within. And so that's one of the things that I think really governs what we can do as part of the donation program. I think along that same line is this is a drug donation program. And we do have a specific amount of supply that has been donated each year. And so that has really dictated how we can continue to expand and what indications we can include. I also think that highlights what some of the limitations of a drug donation program in and of themselves are. And my hope is that this program demonstrates an example of how implementation can be done, but then opens up opportunities for broader access. This is an example of some of the resources that we have created. And in my mind, these are resources that are going to hopefully be broadly available once we finish finalizing them, that integrates all of the different training modules, all of the different pharmacy documents and materials for caregivers that can be used to support future administration. And this has really been what I hope is kind of a catalyst for expanded access. In 2025, Blinatumomab was added to the WHO model list of essential medicines, and our program was cited in the Cancer Expert Report as an example of cross-sector collaboration and how that can improve drug access and feasibility. And so I hope that again, starts to open the door for more of these sustainable access options, both at a national level and at an international level. And I also believe that this has really built team capacity for implementation of immunotherapies. We've worked with 13 spectacular teams across 3 different countries. And when we've asked for feedback from teams, we've really heard that the site leads themselves are seeing the strength build within their teams for teamwork to administer these therapies and then capacity to deliver other novel therapies. And so I really hope that this model can be something that we not only apply to BHAP, but that can be applied to future therapies as they emerge. And I think that this is really critically important because in my mind, if we fail to translate innovation as safer and more effective drugs become available, we really risk widening that global pediatric cancer survival gap rather than closing it. There are many, many, many people that have contributed and have made this program successful. The collaborating institutions themselves, and then also including the site leads at a handful of institutions that also participated in the research project along with St. Jude and the other members of the St. Jude BHAP team. And with that, I'll end and pass it over to the next speaker. I'm happy to answer questions now or at the end.
Thanks, Kathleen. It's been a wonderful presentation of how BHAF has started and what the background work has been done to implement and make it more successful and available to the kids in LMIC. For the want of time, we'll take the questions at the end of all the three sessions. I would like to invite the next speaker, Dr. Revati Raj. Madam doesn't need an introduction. She is a senior consultant pediatric hematology oncology at Apollo Cancer Center, Chennai, and she's one of the leading pediatric hemato-oncologists in the country. Madam comes with a more than 25 years of experience. The team led by Madam at Apollo Cancer Center has implemented Blinatumomab in infants and children with ALL with adaptations of regimen apt for our LMIC setting. She's going to talk about outpatient blinatumomab and other modifications which are used in India and how it's been useful in our setting. Over to you, madam.
So thank you very much, both PHO chapter and the Childhood Cancer Initiative and Caitlin for the wonderful introduction to the work that's been happening both in India and worldwide. And there's no doubt at all that Blina has made a huge difference in our lifetime to children with ALL. So I'll begin with this little girl who had pre-B ALL and who was positive at the MRD positive at the end of induction and consolidation. There was no real reason why she was still MRD positive, and previously we would have given them flag chemotherapy and the morbidity, everything would have been very high because they had multiple infections and taking them up to transplant would have been difficult. This girl, we had used Blina and then done a haplotransplant from her father, and she's now 3 years post-transplant and doing well. And this is, as I said, one drug that made a big difference. And it's started as a drug that we were using as a bridge to transplant. And that's how we started looking at the drug. And the initial work all pointed to how using Blina rather than chemo had better outcomes and more people could get to transplant, like the girl that we heard in our case. And the outcomes of transplant also were superior after the children received blinatumomab. And if they had refractory ALL, also they responded. And hence, this was our initial experience where we used Blina for 16 patients, and we could get most of these children into transplant. And most of them had haplotransplant, and it didn't increase the risk of GVHD that high, but during transplant, they did have cytokine release, and the main toxicity was that the CRS rates during transplant was higher in this group, and a lot of them needed tocilizumab or anakinra during transplant. And out of the Blina children, 2 out of 16 had relapsed, but they're still alive because we went on to giving them CAR T. But at the moment, at 9 months, we have 10 children out of 16 alive. This little baby was only a few months old when she came to us with a white count of 400,000, huge liver, huge spleen, and ALL induction was very difficult. And at the end of ALL induction, she was MRD negative, but the liver was very big. She was in hepatic encephalopathy, and the parents signed a form for not for escalating therapy. And slowly and steadily, she improved over a period of 4 to 6 weeks. Then we gave her a course of Blina, and at the end of it, you can see the dramatic difference. And she could also go in for transplant at the end of this Blinatumomab therapy. And she's now about 8 months post transplant, doing well. So again, this is something that we've brought Blina to the forefront in high-risk ALL. These are the groups that we're using: 17, 19, Downs, if they had RAS pathway genes, KMT2A, and infants. So this is something that we discussed way back in 2014, and during COVID. Where will we use Blina is something that had guidelines, but how long to give? And there were a lot of papers on T cells and how they got exhausted, because remember, we needed the T cells for the Blina to work. So after 14 days, there was T cell exhaustion. So a shorter course of Blina, 14 to 21 days, and giving a gap for 7 days was better for the children, because that meant that they could recover, the T cells could recover, and without the T cells, the drug doesn't work. So when we discussed within our group, we know that each of these vials costs a lot of money in our country, and we had to import it on a name patient basis. The infusion was prolonged, which means in our hospital being private, they had to pay bed charges per day. And we were always worried about the cytokine release. In fact, one of our first patients who had active disease, we didn't want to waste some extra drug we had, and we gave a little bit extra, and she had the most difficult cytokine release, and came out of it. So even small amounts of doses mattered, and CRS is real with Blincyto if we don't follow the rules, especially those with heavy disease burden. So we now know that we have to reduce a little bit of the disease burden before we can use. So when we counsel families for Blina, we say that the first 3 to 4 days, it has to be done as an inpatient. They get admitted, they have a central line. The first 48 hours, we prepare the drug in infusion bag, because they are inpatient and it goes through an infusion pump. And as Caitlin mentioned, that we have to give it through a zero point 0.2 micron filter. So the vial comes either as a 35 milligram or a 38.5. So we have to be careful how we do the calculation, and we dissolve it in 3 ml water. But what really makes it difficult to use for long time is the stabilizer, because we just have 10 ml of stabilizer, and without the stabilizer, we can't keep the drug for long. So if we add the stabilizing solution, we can keep it refrigerated for 7 days. But without the stabilizer, we cannot. So this is where all the calculations and things that our team does comes. After the first 3 to 4 days, once we know that they are tolerating the drug, then we can convert the patients into using infusion pumps. Now, there are two different infusion pumps. Baxter, which does the does the multi-rate flow. So it comes at 5, 7, and 12. So the amount of liquid in this balloon pump is around about 270 to 280. So if you do the 5 ml per hour, it'll get over roughly in about 24 hours. But the 7 ml and 12 ml, you can prolong it to 36 hours, 48 hours. So we just have to decide what rate we need, and the rate is set in the little key there. And there are other versions of pumps like the dose diffuser. And this is how we do the calculation. That if there's active disease, we give lower 5 mics per meter square. And if they are MRD positive and we're dealing with less disease burden, we can go up to 15 mics per meter square. So we pre-medicate them with a single dose of dexamethasone, 5 milligrams per meter square, with the first dose of blinatumomab that we are giving, IV, one-off dose. And for the first 5 to 7 days, we cover that period of CRS with Jakavi because we are going to do this as outpatients. So I've just put a few sample calculations. So supposing our child is 15 kg and the body surface area is 0.65 meters square and they are MRT positive, we need 15 microgram per meter square per day, which comes to roughly 9.75. Each 1 ml, each 3 ml will contain 38.5. So 1 ml will contain 12.8 and 1.5 ml will contain 19.25. We don't want to waste. So we add half of this in bag 1 and half of this in bag 2. And if we want to give only 9.75 but not give so much, then we give it over 48 hours. So because we want 9.75 per day, but what we have is 19.25 in one bag. So each bag is given over 48 hours. So we set it for 48 hours. The little baby that we saw, even if we do all this calculation, the minimum amount we can give her if we use each bag for 48 hours, still we will be left with an ml which will not be it won't be possible to use for her. So this is when we try to cohort, and if there is some other high risk child that needs Blina, we try to cohort 2 children if they are very tiny and we don't want to waste. Slowly you will see the balloon pump coming down, and we tell the parents to check that the dose diffuser is coming getting smaller and smaller, the balloon inside. All these pumps come with an inbuilt zero point 0.2 micron filter, so we don't need zero point 0.2 micron filters. So they're given little pouches like this, and when they are outpatients, so they carry these balloon pumps in a little pouch and come to outpatients. So once it's reconstituted with a stabilizer, I said we can keep for 7 days. So this is what we try and do so that without wasting. So each child, we will need about, on average, 5 to 7 vials of Blina. So we give them in advance how many vials that we need to get the money for. And this is at the time of discharge, we give them an OP instructions leaflet to say this is the infusion pump, and this we have in different languages so that based on what should the parents look out for, and if there is a fever, they will come for readmission. So that's not done as outpatients. And so if they didn't have a fever, then we have 24-hour access to come back to the ward so that the nurses can check how they are doing, how they are progressing. Um, there will be an occasional child in which the 48-hour infusion will get over in, say, 42 hours. So we will have to be vigilant and see how they are progressing. So with this strategy, maybe out of these 43 children, for about 3, we've needed to use a second or third dose of steroid because they had intermittent fever. But most of them we could get away with a minimum first dose dexamethasone. But as Caitlin correctly pointed out, that we know we need a whole team of people. We need clinical pharmacists. We need to make sure that the drug is prepared in the sterile area, and the parents know when to come back, and that's really important. And they need to be able to come back on time. So they stay within about 15 minutes distance from the hospital, not very far, even when we do the ambulatory Blina. So out of our 43 children, majority have been relapsed ALL as a bridge to transplant or refractory ALL. We have used in a few who were high risk upfront and infant ALL. And the challenges that I mentioned were the high cost. And here again, we can get Blina with and without the bill. So if the families are paying cash, they can avoid GST. The prolonged infusion, we use the balloon pump and have them admitted for the first 48, maximum 4 days period. After the first and the second bag are over, they are done as outpatient, and the cytokine release can definitely be managed with a combination of DEXA and Jakavi. So I want to sincerely thank Shweta and the team for this opportunity. All of the patients and families. Now, Blina has taught us a lot of things, because once the patients have received a course, some of them have even come forward to sponsor for another child because they've seen what difference it does for their child. So a lot of what we've done is because of our own parents coming forward to help other children who are in need. The clinical pharmacists, and we have a beautiful physician assistant and nursing team who've been the backbone of this outpatient Blina program, and our PICU team who've helped with all the difficult patients who had the CRS and put these protocols in place to prevent cytokine release. I'll be happy to answer any questions. Thank you.
Thank you so much, ma'am. So you wonderfully explained how it has been adapted in our setting and shared your vast experience of using Blina cost effectively, as well as how we can use in our setting. So we'll take the questions at the end of this session. So now the next speaker I'm going to invite is Dr. Gauru Narula sir. We all know sir. Sir is a professor of pediatric oncology and health sciences as Tata Memorial Hospital, Mumbai. He is a project lead of CAR-T and Cell Therapy Center at ACTRAC. Sir has been past convener of Pediatric Hematolymphoid Group. Sir's special research interests are pediatric hematolymphoid malignancies and histiocytic disorder, and Sir has done tremendous work in cell and gene therapy and immunotherapy. He's going to talk about the experience with BHAP and the things which are in process to bring the Blinatumomab to India and other LMICs. So over to you, sir.
Thanks a lot, Maharshi, for that introduction. I don't think I've got the access yet for sharing my screen on the iPad. Okay. Okay, I will do this instead. Yes. Right. Okay. My screen is visible.
Yes, sir.
Yeah. So apologies, I was trying to share from my iPad first, but I think that access is not there. So I'll just go ahead with the. So it may be because I'm presenting from one computer and speaking from the other. So thanks for the introduction, Maharshi, and to the Indian Childhood Cancer Initiative and PHO for this webinar. I will be talking about the Blinatumomab Humanitarian Assistance Program, the Indian perspective on behalf of what Caitlin was speaking from the other end from the implementation. So we were the implementers of what she has been studying. So unlike what Revati could tell you, we were completely a part of the program. So this was not patient initiated. This came from through the program, and because it came through the program, we had to abide by the program's uh, maybe you could call it restrictions because we were not able to do the kind of things which Revati might have been telling you about. So we had to strictly follow the FDA guidelines for its approved use and for its administration, and also give the complete 2 cycles, and also report to Blinatumomab, the assistance program, give them the feedback, etc., about the vials and everything. So it was completely part of the program. And what we'll be telling you is how it worked in real life from our perspective. So this is just a reminder that in when it comes to outcomes of pediatric cancer, India, our country, comes a gentle shade of pink, which if you see the scale below, puts it around as 50% of overall outcomes. So this is the Lancet Oncology Commission report from 2019. Maybe we are a slightly pale yellow by now from a pale pink, but we still have a long way to go. And part of that reason has been because of acute lymphoblastic leukemia. So why the program was important to us, I need to put it into context. This is the left graph shows you the number of cases registered in our group at Tata Memorial Hospital since 2010 onwards till 2022. You can see we now see more than 1,000 new cases of hematolymphoid malignancies every year. And the graph on the right above shows you the amount of funding that we have been able to raise. And this is really important because without this, the program would not have been a success at all. So by 2021-22, by the time this program was getting introduced, we had sufficient funds to treat all the patients for the frontline therapy at least. And the bottom graph shows you how our treatment refusal and abandonment rates have been falling. And by the stage of 2021-22, by the time we were introducing this program, our treatment refusal and abandonment was consistently below 3%, which means literally every new case which could come to us, we were able to treat and take them through their entire treatment. So what we are presenting to you is actually probably the real world evidence in an ideal way that consecutive patients, irrespective of social class and paying capacity, what their outcomes were. This graph is, of course, which all of you are familiar with, and that's the improving outcomes of ALL. Why I show it over here is because it always puts things in context, and we in LMICs, especially including the centers in India, stand heterogeneously across between 60 to 80% outcomes. So this is where we are. But what has always happened is that when we looked at our data of relapsed refractory ALL, in the period of 2012, 10 to 16, you can see that the outcomes have been very, very poor. And this is not because of the non-availability of transplant. Despite all that, most of the patients are just not able to go through the treatment. So this is something which really needs addressing. We have been improving outcomes, but as you know, without before the advent of immunotherapy, there has not been much movement. This study by Nguyen et al., which was published in 2008, looked at this trials which were divided ALL relapse into early, intermediate, and late relapse from the time of duration from the initial therapy, and looked at trials which were done earlier, that was in the 80s and 90s, and trials which were done later, which was in the late 90s and early 2000s. And you can see the paler graph shows the later trials and the darker lines show the earlier trials, and the needle has not moved at all. So basically, till till the till such time, the time of relapse has been indicating what will be the outcome for decades now. And until the immunotherapy came in, there's nothing has moved. So what we know now is that we have been trying to address this, by using multi-center collaborative randomized controlled trials. We started ICICL in 2014, and now we are trying to improve the outcomes further with the, availability of blinatumomab and inotuzumab. And we've been developing the CAR T cell therapy program, but that is also for beyond second line. So to get to that area, it has taken a huge effort. So in this context, in this background, the Blinatumomab Humanitarian Assistance Program started. And it was on 23rd February 21 that we received the first consignment of these vials, which were delivered by direct relief. And this shows the first patient who started the infusion, and all of us gathering around for what we thought was a really historic moment and changing the landscape of relapse refractory treatment at our center. But there were several challenges. We deal with very high volumes, nearly 60 to 70 patients with relapse refractory BLL a year. We have high bed occupancy and turnover. So it was important to be very selective about the patients that we could take initially. There were other challenges. We had to give the full 28-day cycles and both the cycles. We also have a very high staff turnover, including a lot of trainees. So there's a lot of turnover, including from the nursing side. So every time we require retraining. Uh, there's a constraint about the availability of pumps and cassettes. There's only one supplier which supplies the correct pump, which is the CAD pump. Though there is no objection to using the balloon pump, but it is also if you have to establish a steady infusion rate which does not decrease towards the end of the volume as the balloon contracts, it can slow down.
He left.
This is
भाई
this
वो
is.
किशोर तेरा टॉवल लेकर आना है वहीं पे वो है
I'm
बहुत
sorry
ये हो रहा है
about that. Uh, Okay, somebody else. Right. Okay, not related to this. Yeah, I'll continue. So high. So there's only one pump supplier, and it's difficult to repair them if they go bad. And the bags we were not getting off the correct volume. The correct way is first 7 days you're given the 24-hour bags, and the next remaining 21 days you're given 96-hour bags, but only 48-hour bags and 24-hour bags are available in India from the vendor. So that restricted the way we could administer the drug. There's a lot of monitoring involved, and I'll just touch on that in a bit. And there are costs. So, the drug is being provided free, but there is still a lot of supportive care and subsequent therapy which is involved, which we think for a relapsed refractory patient, including Blinatumomab, even without the price of the drug involved, it's about 5 to 6 lakhs per patient, excluding the cost of transplantation. So patients are also exhausted by this time, and it is not that as if everybody would jump just because the drug was available. And what about further therapy once they've been put into remission with blinatumomab? Not everybody is able to go for a transplant, especially in our country. So here comes what we were, our selective wave that we move forward. This shows you one of the adaptations that we made. We look at the CD19 expression before selecting a patient for CD19 directed therapy. Here are 3 examples. You look at the top left graph, which you see, and you will see that the expression doesn't seem very bright, but you can see that almost all the red dots are within the circle. That means that is in the square. That means that almost all the blasts express CD19. Compare that with the one in the center. It looks much brighter. So the expression is bright, but if you look at the graph, you will see that nearly 8% of the blasts are CD19 negative. So that means that there's a significant population of blasts which are not exhibiting CD19, and this patient is likely to fail CD19 directed therapy. Even more stark example is the one on the right panel, which shows you a large population of blasts, and they really seem to be brightly positive. Almost anybody would label this and say that this is indeed a CD19 positive, bright positive. But actually, when you look at it, you'll see such a large percentage of cells which are outside, and that's nearly 5% of the cells are outside, and it's a very large number, as you can see in this graph. So these patients are less likely to respond to CD19 directed therapy. So we were a bit more selective when we took them up, so that we would only be able to take the patients who were most likely to benefit, since we couldn't give it to everyone anyway. The other adaptation that we had to make was that how do you detect your MRD when your gating strategy is gone? So now, you've eliminated all the CD19 B cells. If your therapy is successful, they're gone. So how are you going to now gate? You ask your flow cytometrist, and they all tell you that the first gate which they put for B cells is CD19. But now you can't do that. So if you keep doing that, you're going to miss your CD19 negative relapses. So then we standardized a 15-color high sensitive flow cytometry. This was published in the European Journal of Hematology. And we used our initial patients on blinatumomab and CAR T cell therapy, which we had open trial at the same time, and use that to standardize this approach. This is published now, and I would urge all of you and to be in touch with your hematopathologist to be following similar strategies. So this is the impact of the program at our center. We have now completed what I would like to call a bite ball century. From February 21 to March 26 in 5 years, more than 100 patients have been treated. Median age was 9. Relapse refractory, very early relapse, and early relapse and late relapse were sort of evenly distributed. Very early relapses have not been that many yet, because most of these patients we directed towards the CAR-T trial, which was also simultaneously rolling at that time. We've given more than 152 cycles and more than 4,200 treatment days. During this period, you can see how the number of patients we have been treating every year has steadily gone up. When after 2022, we are now consistently treating 25 to 30 patients plus. And this year, we are expected to cross 40 to 50 patients in 25 alone, in 2026 alone. We have had to make several adaptations, maybe some similar to what Reti has been telling you, but some slightly different ones which we also had to make. We had to, of course, there was a constraint. We had to split it to 48-hour bags. We have shifted to outpatient management, initially only the second cycle, and now we shifted to entirely outpatient post day 8 in cycle 1, and now we are trying to push that to even earlier than that. Because we are large groups and multiple patients, so we created WhatsApp groups, and that has allowed us to communicate freely and rapidly with each other. And virtually any patient on Blinatumomab, there'll be 4 or 5, 6 of them simultaneously, and all of us know the status of each one of them because it's constantly being updated and posted on our common groups. That's a sample of a patient now carrying his cat pump around, and they're able to go home on this. And this has happened to been able to decrease our hospital stay by more than 70% in the last 5 years. And the most important part, what are the outcomes? They, as you can see, are now very, very impressive from the earlier decimal graph, which I showed you just in the previous decade. We have seen this graph move up to such hard primary outcomes now. We are getting the red line shows you the EFS, which is now around 70%, and the OS, which is around 75% 2 years down the line. And it is, as you can see, evening out over there and seems to be like holding now. And there's some other interesting work which we did while we were studying this. This graph shows you the T cell expansion, which was occurring in cycle 1. This is just one of the things which we have studied. We have looked at a host of T cells, all the T cell subsets. We have looked at cytokines. This is work which Swami was doing when he was with us, but he's in Japan now. But we are now planning to present this in SciUp 26, so be on the lookout for this. This is just a teaser from that. Cycle 1 shows you good expansion till day 14 and sort of evening out till day 28. You can see we start with low lymphocyte counts, probably because they're just coming out of chemo. But look what happens in cycle 2. There doesn't seem to be any change at all. The baseline, TLC seems to be a bit higher, obviously because by now they've gone into remission and they've had nearly 4 to 6 weeks now of chemo-free interval. So the lymphocytes are better, but there's just no expansion and stimulation in the second cycle. Really makes us think whether the second cycle is required at all. So we have had now a huge impact on our outcomes. We are seeing 20 to 50% improvement across the various subtypes of relapsed refractory ALL over the historic cohorts. It's now compatible with data which we are getting from the high-income countries, and even the toxicities are equivalent. We are not seeing such a high rate of CRS at all. We are seeing a very, very our major problem is neurotoxicity, which is occurring in about 5 to 6% of patients. And this is also equivalent. We have achieved all this even though 1/3 of the patients so far have not been able to proceed for transplant. But the biggest impact has also been in opportunity costs. Because of the reduced supportive care compared to intensive chemotherapy, which we give as second line to these patients, we are now able to divert the funds that we have, limited resources that we have, to treat other patients. So we are able to do more good for more patients, not just with the patients who are being treated here. And we have standardized the adaptations that we have made. Now, many of these are now published and some will be published so that, they become a reference standard for people who are seeking to make these adaptations. There's also been a global impact. It has made it to the WHO Essential Medicines list, a proposal that we were happy to, support. And we had presented this work with Caitlin and Sean Libert from Amgen and Ellen Cho from Direct Relief at the UICC World Cancer Leaders Summit in Melbourne. And I think that has helped in what Caitlin was saying, that making a global impression and about how this drug can be accessed and actually rolled out all over the world. But what next? And this is something which I have raised with the BHAP team, of course, and Amgen directly also in private and public forums. That charity is not a plan. We are getting this drug and we'll be able to treat hundreds of patients and we are going to treat hundreds more. But what next? What's the plan? Are they going to ever introduce it over here? We don't know. Uh, this drug is now moving into first line, and that's going to increase the consumption of this drug in the developed world by tenfold. So, what are the plans for bringing it to us after that? I think that the gap is going to increase and not going to decrease, despite the availability of this program. Amgen is now moving to the subcutaneous injections of Blinatumomab. And we were in talks with them to include India as part of the global trial so that they could, subsequently introduce it in market approval. There's been no movement at all on that front. So if there's going to be no market access, we can't just depend on a donation program to continue what has essentially become the our Blinatumomab is now integral to our second line ALL program at Tata Memorial and increasingly across many hospitals in the country. So we need to have a plan ahead. This is also affecting other newer drugs. Recently, we came to know that asciminib Novartis was going to start the asciminib trial in India. But once they learned that Blinatumomab is not available commercially, they had to back out because their standard arm, the control arm, had needed to have Blinatumomab in it. So it is not just the access of one drug that we are suffering from. The spin-off effects are occurring in all the newer therapies also which are coming, since the drug itself is now in the first line. So that's it from my side. This is with a lot of love from two very large teams, both at TMH Parel and at the ACTREC campus. And a lot of people are involved, which makes this possible and allows me to present for you. And as you know, I'm from the Pediatric Oncology Division at Tata Memorial Hospital and very happy to work with a great bunch of colleagues. A special shout out to Badirao, who helped to establish and start the program, and Sham and Chetan, who are mostly running the program on the day-to-day basis now. With that, thank you for your attention and happy to take any questions along with the rest.
Thank you so much, sir. Sharing your experience with the BHAP and flagging the worries which are going to be with the access of Blina and other medications in future. So I think we can now take questions. I'll hand it over to Dr. Arun. If we can go to the question and answer session.
Yeah, so on behalf of PHO chapter, I thank all the three speakers for this wonderful and informative talk. So we'll move on to the question answer. We have few questions in chat box. So if Kathleen is there, then first question from Dr. Sujata Sharma. We fulfill the criteria. So how do we can procure the drug through this program?
Yeah, that's a good question. And one of the things that I was trying to highlight in the presentation as well is that we are limited based on the drug supply that we get from Amgen. And if we don't have any additional drug supply for the year, we can't onboard new teams. So it's not to discredit that there are many, many very qualified teams that would meet the criteria for the program. We just only have the supply that Amgen gives us.
Okay. So, Dr. Ramandeep is asking, with Blina, as per WHO, they include in the essential medicine list. Is there any translation to the national essential medical list in LMIC now, including Blina? I think anyone, Gaurav sir, or anyone can answer about that.
Well, one thing is, yes, making it to the essential medicines list, which means that governments, that puts pressure on governments to make it available to their citizens. And especially, it also allows pediatric bodies like us to, some leverage to go to the government with. But if the company is not making it commercially available, and not applying for market access in the country, that whole thing becomes a bit redundant. So the drug belongs to the company. They have to
Okay.
come to India to say that yes, we would like to market it, and if it is available, and then then we can pressurize the government. This is an essential medicine, and do some price control on this, or include it into this scheme, that scheme, etc. All that, but the first move has to come from the company.
Sir, anything on the patent of this drug? Any generic version we can see in the future for this drug?
You're asking me?
Yes, sir.
So there's a problem. Bytes are difficult to make. The technology involved is not that simple. Antibody anybody can make now, I guess. We are designing new antibody binders for our CAR-T cell therapy program. It's a lot of people are doing it. The problem comes in the linker. I think the linker technology is very, very difficult, and its synthesis is not easy. So that's where probably most people who are trying to make bytes are failing. I think that technology is very securely protected. Not to say that a lot of people are not trying, but very few companies have successfully managed to make bilineage T engagers at scale.
Sir. So question from Lakshmi that to Dr. Revati, ma'am. So we assume that there was no incidence of CRS later on in the course in children who did not have any issue in the first 48 hour of Blina delivered as inpatients. So ma'am already answered for that. Yes, there is less chance of CRS if it not happen in the first 48 hour. And then question from Dr. Deepak Bansal to ma'am. Jakavi used in high risk cases as prophylaxis along with the DEXA or as only as the treatment of CRS. So, ma'am.
Yeah, I mean, after we've used the Jakavi along with DEXA, we've not needed to readmit the children for CRS or for fevers. So the first 5 to 7 days, it depends if it's a smaller child, one strip we can use for 7 days. If it's a bigger child, then we'll only come for 5 days. So that's why I said 5 to 7 days.
Okay.
So it's not that only for high risk we use Jakavi. Everyone gets Jakavi. This is to prevent CRS.
Thank you, Dr.
And we
Revati.
only use 14 days total.
Right. Thanks,
Yeah.
Dr. Revati. So we have never used Jakavi, and I think we've got away with DEXA. I'm just curious to know, has Gaurav used Jakavi for CRS prophylaxis?
No, not at all. We're not needed to use, but I think I can see where the difference, because I think Revati highlighted several times that she's using it in relapsed refractory patients and as a bridge to transplant, whereas we have been using it as second line therapy effectively. So what happens is that when we use it as second line, our patients undergo a regular relapse refractory kind of induction, whatever the protocol was in vogue over the previous 4 years. And then after they undergo an induction, most of them are low MRD or MRD negative. Then we apply for the BHAP program. They probably even undergo another cycle initially. Now we're getting it faster, but initially another month or two could pass before the BHAP would arrive. And they would be very low disease burden or even MRD negative by the time they would be getting the Blina. Now we get it pretty fast after the induction because we have enough cases, so there's always a backlog. We have vials which we are able to start the next patient on. So we do treat a lot of patients with lower level disease, but we don't see CRS at all, hardly any. We see some neurotoxicity, and it can develop in week 3, week 4. So it's not to say that it can't happen, and it can happen in cycle 2 also. So you need to be on the watch if you're giving. But if you're not giving a second cycle and you're giving short duration, then probably only the first 2 to 3 weeks, are the first week is the most crucial of that. Yeah.
I will add that with this approach, looking across our different sites, we have a rate of CRS that's severe that's less than 2%. And I think it is, as Dr. Gaurav was mentioning, because the disease burden is so much lower. And so we really haven't had an issue with that across the centers.
Yeah, the kind of high risk cases which I think Revati has been mentioning, in our center, they have been going for CAR-T. So we are not they have not come towards Blina. If they had a high disease burden, we would have taken them towards CAR-T.
So, Gaurav sir, from Mercy, what strategy do you suggest for a patient with minor blast population which is CD19 negative, where resource is not a problem? Shall we still defer Blina in this case?
No, not really. That's not the FDA indication. In the FDA approved indication, they have not asked you to look at the CD19 expression. So if the patient is a BALL and has got CD19 expression, you don't need to see whether it is not there or not. But the chances of it not working are high if you got a CD19 negative population. So it might be a waste of effort. You have alternatives. So you can go for Blinatumomab and take up. Well, there'll be challenges in the transplant, but there are other ways to get around it. Then even if resources are not a problem, you will end up wasting a lot of money. And secondly, the disease progresses in that time. Your CD19 positive population gets knocked out. Your CD19 negative population keeps rising. So it is going to lower your efficacy. But
So, sir,
it's
again,
not binding. It's not binding. If you and the family agree, go ahead.
sir, again, question to you. It is known if post-consolidation MRD positive disease can be treated with Blina and some chemo, can we get away without transplant?
This must be Deepak.
Yes.
Yes. Yeah, Deepak bounces from you always. No, so once the patient is MRD positive post consolidation, as far as we are concerned and all available literature, this patient is now onwards a candidate for transplant and CR1. So that means that the moment you achieve a CR, you should be going for transplant. Now, just to draw the distinction here, in the BHAP program, to qualify for Blinatumomab in the FDA-approved indication, refractory means 0.1% at the end of consolidation. So we do get a lot of patients who are between 0.01% and 0.1% who are not eligible for Blina. So I can't really fully answer that question for you. But yes, even if we go give them Blina, if they were above 0.1% and they become MRD negative after Blina, and should they go for a transplant? Yes, they should. Are they going for a transplant? No, most of our patients are not going for transplant and they are getting away with chemo. But that data, hopefully, we will be able to build up over time and share it with you. But our aim is always to push these patients for transplant.
Okay, sir. So, from Dr. Shruti Kakad, are there any resource for training the team for drug preparation for Blina and how to give it? Is there any resource, Dr. Kathleen or Maharshi, anyone who is using this program?
Caitlin should be the best one.
Yeah.
Sorry, Dr. Gaurav, I didn't hear what you said.
So, Dr. Shruti is asking, are there any resource for training for the staff for preparation, how to prepare this drug and how to give it? Because there is many issues in the preparation and is there any resource for that?
Yeah, so that's one of the things that we have been working on over the last several years is to create a multidisciplinary training toolkit and implementation planning toolkit for different teams. We are in the final stages now of it being ready and being finalized, and then is going to ultimately be something that's available on the Cure for Kids platform. And so I'm happy to share with this group once that's available.
Okay.
That's the
Thanks a
whole
lot
point.
for
We really wanted to make things that would be useful for whole teams.
Yes. So, how common is the neurotoxicity? Gaurav sir, you said there is 7% discontinue because of the toxicity. All were the neurotoxicity, CRS, or some other toxicity you observed during this time?
Yeah, I think 3 were for disease progression, but the rest were for toxicity, almost entirely due to neurotoxicity. So I think one patient probably had for CRS, but the rest were all for neurotoxicity. So you can get seizures and they can come without warning and they can come even in week 2, week 3. But of course, chances are usually earlier. The maximum time when seizures occur, I think they occur when we have just been stepping up the dose. So after 7 days, when you step up the dose, after day 8, at that time, there's a good chance that they might have a seizure. And it can come without warning. Most of the neurotoxicities occurred in patients who had past CNS events. That means they either had a CNS relapse or they had something prior, some CNS complication. Of course, the patient needs to be neurologically normal and CNS disease needs to be cleared for them to be eligible for the BHAP program. But we have generally seen like that might be the case, but if they had a history, they are more likely to have neurotoxicity.
Okay.
So,
But the rates are similar. The rates are very low indeed. So just 6 patients out of 7 patients probably out of 100, 90 plus. So it's pretty low, below 6%.
so
I can
yeah,
say
sir.
that's been
Like,
similar with our St. Jude data as well. Like we've had fairly low rates of severe neurotoxicity. The majority of cases happened like day 2, day 3, or at that day 8 escalation. But they can happen at any time during either cycle 1 or cycle 2.
so like children with Down syndrome, do you suggest this level of prophylaxis in all, or is it who are at risk for?
All Down syndrome should get some type of seizure prophylaxis. That is a change that changed over time. So initially, when recommendations were started, it was just for Down syndrome patients who were older than 10. But then from the COG data, recommendation has changed, and we give prophylaxis to all of our Down syndrome patients at St. Jude as part of BHAP.
Thank you.
Gaurav sir, you said there is only one vendor for this cat pump. For this group benefit, can you share from where we can get this cat pump?
Yeah, sure. They are authorized dealers in India, so they are able to supply. Yeah, we'll share it in the PHO group.
Okay, sir. Thank you all. So I think that's all with the question. If any remaining question directly they can ask, and then we'll wind up the session. So thank you once again, all the speaker, all the participant, and we'll end this webinar here. And thanks once again. Thank you.
Thank you. Thank you.
Thank you very much.
Thank you.